Hello and welcome to The Virus. I'm Norman Swan. Coming up, the impact of long COVID is the subject of a new parliamentary inquiry. We'll hear from the government MP who's heading up the committee, who's also a doctor. This week, 2.5 years after it declared the COVID-19 outbreak a pandemic, the World Health Organization said the end is now in sight. The number of weekly reported deaths around the world is now at its lowest since March 2020. Despite the good news, the Director General of WHO has warned a failure to seize this opportunity will lead to more variants and more deaths.
A marathon runner does not stop when the finish line comes into view. She runs harder with all the energy she has left. So must we. We can see the finish line. We are in a winning position, but now is the worst time to stop running. Now is the time to run harder and make sure we cross the line and reap the rewards of all our hard work.
Meru Sheel is a researcher into global health, infectious diseases and public health emergencies. Associate Professor Sheel, welcome to The Virus.
Thank you, Dr. Norman Swan, for having me.
Pleasure. Is this just wishful thinking on the part of WHO?
Look, it's definitely optimistic, and it's something to be reflecting positively about after 2.5 years of experiencing the pandemic by the community, by the world. If you look at the numbers, there's been about an 18% weekly decline in the number of deaths being reported. Now, that's obviously, we know deaths are always underreported. There's issues around reporting, etc. But when we're looking at the patterns, it's a promising pattern. The trend is promising that there's been an 18% decline compared to the previous week. So I think it is definitely something worth reflecting positively on, but it doesn't mean that we take our eyes away from it or forget that, COVID-19 or SARS-CoV-2 is still circulating. So it's definitely something to be positively reflecting and perhaps thinking about what the next phases of response looks like. And there are lots of considerations, going harder at prevention in terms of vaccinating populations more. We know there are target strategies. There are still gaps in vaccine coverage in certain countries and certain settings and groups. So we want 100%. We want to aim for 100% vaccine coverage, including boosters in high-risk populations like the elderly, healthcare workers, and other geographical settings that might not be as protected as, say, some of the other settings where we have high coverage. So there's still work to be done, but I think it's a positive trend.
So we're all desperate for positive news, but is it vaccination rates that's different this time? Because we've had surges and drops before. Yes, they've gone down to below March 2020 levels, which is fantastic, but we've had this before. What's to stop a new variant coming out? We know a new variant will be more contagious because that's what will make it come out. And that to be more contagious is going to evade the immune system. And we've already seen declines in vaccine effectiveness. I'm just putting the opposite point of view without wanting to be too gloomy here.
No. I think those are all valid considerations that we have to think about when we're responding to a public health emergency. And I don't think that we're saying that may not happen. Of course, we've seen this before. New variants absolutely could emerge. But what we are seeing is really that immunity is building up in the population, both from vaccination and natural infection. We know hybrid immunity does offer a better level of protection compared to just vaccine-induced or just natural infection. We definitely want more and more people vaccinated. So it's possible that we may see another wave, especially as the Northern Hemisphere goes through their winter season this year, and that will give us a little bit more reflection. So I think we have to be prepared that we might see another wave, we might see another variant emerge. That's not out of the question, but that still doesn't mean that at this point of time, it looks like the numbers and the deaths are going in the direction we want them to go in. Of course, we've had advances in vaccination. We have better drugs now than we did 2 years ago. We're likely to see variant-specific vaccines become available more broadly as well. That is, again, another more positive look to it. But also being realistic about how we respond to COVID in the future, because there are lots of other diseases that we need to start thinking about that really have fallen through the cracks over the last couple of years. And I think it's about integrating responding to COVID with other pathogens, other service delivery portfolios and diseases, and routine immunisation, for example, being one of them.
Now, we've had very large numbers of deaths in Australia. We're up there in the top 3 or 4 countries internationally with deaths this year. I just wondered what you think of our scorecard on the 6 points that Dr. Tedros, the Director General of the WHO, said we've got to aim for. So, testing. Well, we're not doing testing very well. We've almost abandoned PCR. We're relying on rat testing, if indeed any testing at all. The Chief Health Officer in Victoria suggested that the compliance with testing is very low. Clinical care, planning for surgeries and treating long COVID. We don't seem to be organised with long COVID treatment. Vaccination, 30% of Australians haven't had their 3rd dose, which means their immunity has dropped to quite low levels. Infection control, well, that's pretty good in Australia. Rebuilding trust in public health authorities, that's not bad here. Managing the COVID infodemic. So what's your scorecard? I've editorialised, given you mine, but what's your scorecard for Australia on those 6 points?
Yeah, I think, look, I do think we've still done really well compared to many other settings. It's, of course, a challenging environment that we're working on. And again, in Australia, we've got to be thinking about what does COVID response look in the future. I think we do have a long way to go in terms of getting our booster coverage high, and we could do more in getting our vaccine booster coverage high and encouraging communities, making access better. I think that there are still definitely needs and gaps there. I'm definitely not saying that we need to be stopping responding or stop preventing the infection. Of course, as an infectious disease epidemiologist, we're always looking to prevent infection. We don't want people to actively go out and get infected, but I think we've overall done well. Yes, we've had deaths, unfortunately, and every death is a number we don't want. But vaccination, we know, is one of the best ways to move forward, and we really need to be encouraging those people who are eligible for their 3rd booster, eligible for their extra booster, the 4th dose. And so I think we do need to be doing that and monitoring the disease more closely and seeing what it means in the context of influenza and other respiratory pathogens, but also other infectious diseases that are emerging, whether it's Japanese encephalitis or monkeypox and other service options as well.
Meru, you've got a job for life.
Yes, not something we want to be kind of celebrating, but yeah, it's definitely busy.
Associate Professor Meru Shewan from Sydney University, thank you very much for joining us on the virus. If the pandemic is not over and we get more surges, there are more measures of COVID impact than just deaths and hospitalisations that need to be considered. About 5% of Australians who are vaccinated will develop long COVID following an infection, and some of these people may develop life-threatening complications such as heart attacks and dementia. The lasting impacts of long COVID on areas like our health and social welfare systems and our economy will be examined in a new parliamentary inquiry. Labour MP Dr Mike Friedlander is the chair of the House Health Committee. He's a paediatrician and one of 4 doctors in the cross-party group. He was also my junior doctor when I was at Children's Hospital in Sydney. Welcome, Mike. I thought I'd just have that declaration of past involvement there. How do you think we're performing, before we get to long COVID, on these 6 points that the Director General of the World Health Organization say that we need to move forward on? Because some of them we're not doing that well.
No, we're not. You're quite right. And the testing in particular concerns me a lot. People have become very complacent, and I think we're relying mostly on rat testing, and I think a lot of people are actually not getting tested, even if they have symptoms. So it does worry me that we've fallen behind with our testing and also with our immunisation. I've certainly had my 4th dose of the booster, and I would encourage everyone to get immunised if they can, and we need to make it easier for people. We also need to keep reinforcing the message that COVID is not just the flu, it's not just a mild cold, and we are seeing if not deaths in very large numbers now, we're seeing lots of side effects from the disease, and as you've mentioned, increased risk of cardiovascular disease, stroke, a whole range of other illnesses. So,
is your inquiry going to look So you've got long COVID, which looks like as if it might be three separate syndromes, actually. So the constellation of symptoms, we haven't got time to go into that on this show. We might in a future one. But you've also got excess deaths, not just from COVID. So COVID's the third commonest cause of death at the moment. But you've got excess deaths from heart attacks, dementia, kidney disease. And the Actuaries Institute thinks that's due to COVID. Is that part of your inquiry, that long-term impact from complications?
Yes, it is. It's something I've been very concerned about, and I've been talking to some of our cardiologists and neurologists. They are very concerned that they are seeing increased numbers of people with heart attacks and strokes that have had COVID sometime in the past. And I certainly want to look at this as hard as we can to see if there are any ways we can reduce the risk, any treatments, any ways of picking up those that are most at risk, and whether there are any markers we can use to see who is at risk. So I'm very concerned about that, and certainly a lot of our physician colleagues are also concerned about that and have been contacting me.
How are you going to do this inquiry? We've got almost no data on long COVID. We've got some small studies, like the one at St Vincent's Hospital in Sydney, the Indepth study. It took forever to get software companies to put criteria on GP software so that GPs can actually record accurately when they've got long COVID. How are you going to know the dimensions of the problem and the impact when you haven't got data?
Yeah, well, that's a very important point you've brought up, Norman. We need to get better data collection across the age spectrum. I'm very interested, of course, in the paediatric age group. I've seen some pretty terrible-looking chest x-rays of kids who've had COVID. I'm interested to know if they're going to have ongoing morbidity, and we need to be recording readmissions to hospital, ongoing symptoms, etc., and try and get better at data collection. And that's one of the questions we'll be asking the Department of Health to do to see if we can improve our data collection with COVID. We also need to record better those who've had recurrent COVID, because that seems to be a big risk too for ongoing inflammatory responses. And data is going to be a big point of our inquiry. How are we going to do it? We're going to talk to as many of the research organisations around the country, and we'll be doing public inquiries around the major capital cities and also in regional areas. But we're also trying to get as many of the general public to send us submissions.
But Mike, you haven't got a lot of time. The waves, huge waves in Victoria, New South Wales, some states like WA are a bit late to the party, but they'll get some as well. So you've got a group of people who are going to come through and get this. You haven't got a lot of time. President Biden's spending $1 billion on research into long COVID. The British are doing really interesting clinical trials in mass populations. You're rapidly trying to find this out. What are we spending and doing at the moment while we wait for a parliamentary inquiry?
We are doing the best we can with limited resources, is how I would put it. And part of our role as a committee will be to make some recommendations to government as to how we can best get our bang for our buck in spending money, not just in our major research organisations, but in particular, I'm very much looking forward to talking to our GPs and seeing how we can support them, not just to manage people with long COVID or recurrent COVID, but to help them collect data for us.
And just finally, I know it's a cross-party committee. How are you going to avoid it being political? Because COVID has become very political. Just take the recent debate about isolation, and the New South Wales Premier wants to remove isolation altogether, so it's reported. Yes,
look, I would make the point that this is a committee inquiry that's going to be looking forwards, not backwards. And we have a very bipartisan response. The Deputy Chair, Melissa McIntosh, the member for Lindsay, has been very helpful in helping frame the terms of reference. We have great people like Monique Ryan, Gordon Reid, Michelle Anandaraja, an infectious diseases physician, but also lay members like Anne Stanley, Peter Murphy, Jenny Ware, and of course Mark Coulton, who's had a lot of health experience in the bush. They're not doctors, but we recognise that the general public's response to COVID is important, and hearing from them is going to be important. So our non-medical members are going to have an important role as well.
Mike Friedlander, thanks very much for joining us on the virus.
Thanks for having me, Norman. It's been a great pleasure.
And that's the show for this week. Thanks for your company. Bye for now.